Okay, I want to welcome everybody to the Resident and Family Support Council that we hold on the second and the fourth Tuesday of every month at 3 o'clock. My name is Lee Moriarty, and I'm the Deputy State Long-Term Care Ombudsman. And I'm so pleased to see all of you here on this call today. It's wonderful. A lot of interest in this topic, which is a really important topic about that money situation and what happens with our money and what happens with that allowance money that comes from Medicaid when you are receiving Medicaid services when you live in long-term care. Just a couple of things before we go ahead and begin this conversation today. First of all, I want to give a shout out to Elevate. I see we got Elevate Care there. We got some residents gathered in the room. Hi guys, hoping everything's good out there, and we're glad you're all here to be able to join us today. So welcome. If there's any other long-term care communities out there where you're watching it in a group, I'd love to give a shout out to you too. So if you want to unmute yourselves and just say, hey, we're here too, let me know, because we'd love to be able to give a shout out to all of you guys as well. As I said, we host these Resident and Family Support Council meetings on the second and the fourth Tuesday at every month at 3 o'clock. And the link that brought you into today's meeting is the same link that you'll be able to use for all of our meetings. But if you can't make a meeting, also know that we always record these and we put them on our YouTube channel. And I'm sure Stephen, who's working in the background there, who you just heard a minute ago, I'm sure Stephen is dropping all those links into the chat. I can see that he's already done most of that. So that's wonderful. It's wonderful to be able to have somebody working behind the scenes that can be able to throw those links up so that we can all access that stuff during the meetings as well. So with all of that being said, I'd like to go ahead and let's get started on today's topic. We've got Suzanne from the Legal Aid Chicago Ombudsman Program who's joining us today, and she has a lot of interest in this topic. So Suzanne, as you're beginning, why don't you share a little bit about who you are? Love to hear a little bit more about you.
Sure. I'm the regional ombudsman for Lake County and one of two regional ombudsmen for the Legal Aid Chicago Ombudsman Program, which covers all of suburban Cook County except Evanston and Lake County. I am also an attorney. I've been an attorney for 20 years now. And and I've been working in the ombudsman program for 10. So that's me.
And Suzanne is one of those people that we reach out to with a lot of our technical questions, because many times Suzanne has such a great insight because she does come from that attorney perspective. And this has been a topic area that has been that she's had a lot of questions about. There's been some things that have been happening recently with the personal needs allowance. So Suzanne, I'll go ahead and I'll pass it off to you. I know you've got some slides. If you want to go ahead and put those up there, that would be great.
All right, let me hold on. Oh, this just put a lot of zoom on the on a different screen. Can you guys see the slides?
Yeah, we see it though in your editing view, not in the presenter view, just as
Well,
FYI.
let's fix that. How's
There
that?
we go. Now we got it.
All right, so this is me. Personal needs allowance. So what a personal needs allowance is the amount of monthly income a resident of long-term care whose stay is paid for by Medicaid is allowed to keep for their own personal use. So there's a lot there. Let's unpack it a little bit. So a resident who is on Medicaid to pay for their stay. So this doesn't apply to time paid for 100% by Medicare, and it doesn't apply to residents who are private pay. Those residents get to keep their income during those times, 100% Medicare or private pay. But someone whose stay is being paid for by Medicaid has to turn over all of their income except for a few things that are exempt. So let's go to the next slide. So residents on long-term care Medicaid are required to pay their income each month to the facility. Premiums for health insurance policies, such as Medicare premiums or a Medicare supplement plan, are exempt, and there are a few other things that are exempt. The only other income the resident is allowed to keep for themselves is the personal needs allowance. Now, if the resident has a spouse in the community, that spouse is allowed to keep some of the income. We'll get to that later. Any questions so far? I'm happy to take questions as they come.
Great. Yeah, I have a question. Could you explain a little bit about what that exempt means? You said they're exempt from the insurance. Could you explain that just a little further?
Sure. So when Medicaid is calculating how much the resident is supposed to pay as their personal portion for their income, Medicaid deducts these other health insurance premiums. They don't include that money as money that needs to get paid to the facility. So that money doesn't count. And then the resident is also allowed to keep their personal needs allowance. And if the resident has a spouse in the community, the spouse in the community is allowed to keep a certain amount of the monthly income each month also.
That's reassuring to know that. So thank you.
All right. Let me see if my cursor wants to be on the right screen. So for many years, the personal needs allowance for residents of skilled nursing facilities in Illinois was $30 a month. It's not indexed to inflation. It's just been $30 a month for decades. In 2023, the Illinois legislature passed a law increasing the personal needs allowance to $60 a month, effective January 1st, 2024. So January 1st of this year. The language, all of the language in the statute that applies here is on this slide. I'm not going to read all of it for you, but it's not much. And it does say subject to federal approval. The Illinois regulators did get that federal approval. So this is fully law that $60 a month is the personal needs allowance for people in skilled care.
Well, that sounds very reassuring because that increase, I'm thinking for people from $30 to $60 is a really huge thing.
It is. I mean, it could be more, but
Absolutely. Yeah.
but it does, it's enough to potentially pay for a cell phone plan. It's enough to potentially pay for a couple of meals of non-nursing home food.
Mhm.
Some of our facilities charge for haircuts, which I disagree with, but it's enough to pay for a haircut.
Mhm.
Um, things like
Yeah.
that. And
That just is a little bit more empowering for people, but like you said, it'd be great if it was more, but this is at least an initial beginning to
yes,
recognize that people that live in long-term care need more money to be able to have that life and be able to purchase things and do things for themselves. So that's
yeah,
one step in the right direction.
there you go. So implementation. The Illinois Department of Healthcare and Family Services. This is the department, one of the departments that administers Medicaid, issued a notice to providers. Providers are the nursing homes on January 24th to implement the change to the personal needs allowance. So that meant that most of the providers, most of the nursing facilities only gave everybody $30 for January because the checks came out before this provider notice. But the provider notice still says effective January 1st. So, with the way we read the language, and there are facilities that disagree with us about this, if you are entitled to $60 a month now, you should be getting that extra $30 for January if you didn't get it in January. They owe you that money. Now, when I say they owe you that money, the way that the personal needs allowance works is if you pay the facility each month or your loved one out of an account that the facility doesn't have any access to, they they don't get to take the money that, like, you just pay them. You should be paying them $30 less each month. But for many people, the facility is their representative payee. Their Social Security goes directly to a trust account that the facility administers for the resident's benefit. So the facility gets the money, and then the facility gives the resident access to the money that they are entitled to. So if the facility is your representative payee for Social Security, then they should be giving you $60 a month for going forward. And if they only gave you $30 in January, they should give you that extra $30 for January. Any questions about that?
Yes, so I just want to make, just for a point of clarification. So the facility gets paid the money from HFS, Healthcare and Family Services. They get that money. So if I had 10 people that lived in my building, just for example, and it was $60 a month, I would get the facility was getting $600 a month that was posted directly, then be dispersed out to the residents. Am I understanding that properly?
No, so the $60 a month is the amount of the resident income that they are allowed to keep. So it's not money coming from HFS. It's not it's money that comes from what the resident gets each month. So if a resident is on Social Security disability, if a resident is on Social Security retirement, if a resident has a pension, those that income comes to the resident, or for Social Security, if the facility's rep pay comes to the facility, and the resident gets to keep $60 of that. It's not money that is being paid by Medicaid. Medicaid only pays the amount that's owed for your stay after after you pay your income each month. So you pay your income for the month, Medicaid, or the facility applies that to the first several days of your stay for the month.
Okay, well, I appreciate you calling me back and letting me know. Thank you so much.
People can make sure
Jennifer
that
Baker, if you could mute yourself.
Bye-bye.
yeah, if you could mute, I'm looking to see who that is.
It's Jennifer, I believe. Jennifer Baker.
All right.
So Suzanne, there is a question. I think Mary,
Yes,
Mary got a question. Would you like to unmute yourself to ask that question?
Yes. As I understand it, the $30 minimum was federally required minimum put in place in, I believe, 1986. When it was changed last year for Illinois, Illinois was one of 4 states that still had it set at $30. The other states were, I think, Mississippi, either Mississippi or Alabama, North Carolina and South Carolina. So we were one of the final 4 to change it. There is a bill currently being worked on that asks to increase it to $90 as well, and that's already been is in the process of being implemented. So it hasn't been passed yet, but implemented into being worked on.
That would be great. All right, thank you for that, Mary. And so next we come to a problem that has shown up since we have started implementing this the $60 a month personal needs allowance. So residents only get to keep $60 a month if they have $60 in income to keep. This is a problem for residents who receive SSI. So what is SSI? SSI provides monthly payments to people with disabilities and older adults who have little or no income or resources. So these are many people who don't have a work history to get Social Security retirement or Social Security disability. And it's different than Social Security retirement income or Social Security disability insurance. SSI pays a fixed amount each month for someone in the community. When someone who is on SSI enters a skilled nursing facility, the Social Security Administration drops their income to $30 a month. So Social Security is paying $940 something a month until you go into the nursing home. then they're paying 30. And that doesn't matter for purposes of getting your stay at the facility paid for. Medicaid pays the rest. But it does mean that residents of skilled nursing who are on SSI do not have $60 a month in income to keep. They only get $30 a month in income from SSA. So what we found is that there are a lot of residents that we serve in Illinois who are on SSI and are not getting to have the $60 a month. Mary, I
sounds-
see your hand up.
Mary, did you have another question? Or did you just not lower your hand?
I didn't hit lower it. I apologize.
Oh, that's
That's
okay.
okay.
There are a couple of questions. There is a question in the chat, Suzanne. What if the resident uses a direct express card and they are only receiving the 30? How do they get the additional 30? Do you
They
know anything
don't. So if you're getting your Social Security on a direct express card, what you're getting is $30 and you're still allowed to keep that $30, but there isn't any other income that you have that you are allowed to keep. There's no other income. And we understand how unfair this feels. We understand that it's a problem, but right now it's the way it is. And so there are a couple bills pending in the Illinois legislature this year that might fix that. Who knows if they'll pass, but it is something that we are aware of and have identified as a problem.
Yeah, and I know, Suzanne, that's something that you've identified early on. And that was one reason why I'm inviting you to talk about this topic, because you've been very involved in trying to make sure that everyone was getting their fair due, that they were getting the money that they needed to have. There's another question. If a resident started Medicaid on January 1st, are they entitled to keep their tax refund from 2023? Do you know about that?
So a tax refund from 2023 would be considered income in the month it's received, and if there's any leftover, assets thereafter. So in the month it's received, depending on how much the tax refund is, if it's if it gets you to less than the private pay rate of the facility. So you have your regular income, let's say that's $1,000 a month, and you get $1,000 in a tax refund. That would be less than the private pay rate of the facility. There is no facility in Illinois that charges $2,000 a month for skilled nursing. Then you would have to turn over that tax refund to the facility, unless you have a spouse in the community. And we'll get to the spouse in the community later. But
and there's another question. When the resident, what happens?
There's one more thing about the tax refund.
Oh, go. Yep, sorry.
So if your income is, $4,000 a month and you got a $10,000 tax refund and the facility's private pay rate is $10,000 a month, then you would have to pay the facility $10,000 that month, but your income was $4,000. You would get to keep that other $4,000 as long as it doesn't put your assets over $17,500. I know this is a lot of information, a lot of numbers coming at you, but basically if you get a tax refund and it's small, you're going to have to pay it over to the facility, unless you have a spouse in the community. If you get a tax refund and it's really big, you might not have to turn all of it over.
That's a great, simple way of putting it. And I wanted to make sure that Janelle, because I'm not sure when she wrote this question into the chat, about that resident receiving that Social Security and getting that $30 from Social Security instead of the 60. I want to make sure that she understands the reasoning for that you're not going to get the 60. You're going to get the $30. Janelle, if you don't understand that, if that didn't get explained well for you, let us know, and Suzanne will make sure that she just goes over it again. So just want to make sure. And also Alan said he would like to speak. Alan, would you like to unmute yourself? Alan, while you're unmuting yourself, I'm going to go ahead and have another question that was in the chat also put out to Suzanne. What if a resident has no income at all and enters into a nursing facility?
So a resident with no income at all going into a nursing facility could get on Medicaid, and Medicaid would pay for their entire stay. They wouldn't have to, turn over any non-existent income. That resident also could potentially apply for SSI and get in order to get $30 a month. But other than applying for SSI and getting that $30 a month, they would not be able to keep anything because they don't have anything coming in.
Okay. And Alan, I'm not sure if you should see where the mute is. It's typically at the bottom of your screen, but sometimes it could be at the top of your screen. If you would like to still ask that question, Suzanne could go ahead and move forward, but while you're seeing if you can find that place to unmute yourself, and then just feel free to say, excuse me, and Suzanne will answer your question.
All right. So personal needs allowances in other types of facilities. So we've covered skilled nursing facilities, but there are other long-term care facilities where where people are covered by Medicaid. So the personal needs allowance for a resident of a supportive living facility is $90 per month. And residents of supportive living, if they are on SSI, get to keep their SSI because their SSI does not drop down to $30 a month. The supportive living facility is not considered an institution for purposes of the Social Security Administration, so they get to keep that money from SSI, which they then have to pay to the facility as rent. But there's no $30 issue there. The personal needs allowance for residents of ICFDDs is $60. Also for MCDDs, medically complex for the developmentally disabled facilities. And the personal needs allowance for a resident of a specialized mental health rehabilitation facility, a SMRF, is $60. So I wasn't able to get 100% clarity on whether this SSI issue applies to SMRFs. I believe it does. I believe the SMRFs are considered an institution for purposes of the Social Security Administration. And so SSI residents of SMRFs on SSI, I believe their income is dropped to $30, so they only get to keep the $30. I have not looked into this for ICFDDs or MCDDs.
So that was a question. I received a question this week regarding the MCDDs. So if they has that always been at $60, or did that just change with the new legislation that happened after the first of the year? I thought that changed a while back.
The ICFDDs definitely changed a while back. I'm not sure for the MCDDs. I can tell you that I got this information from the Medicaid policy manual online today. So it is accurate as of today.
Okay, perfect. That's what we care about. That's what we care about. So thank you.
Actually, yesterday. So it was accurate as of yesterday, but they haven't changed it.
No.
So, and then I promised we would talk about spouses in the community. So the amount of a resident's income or assets that a community spouse is allowed to keep is referred to as spousal impoverishment. It's actually regulations they put in place to prevent spousal impoverishment, to prevent the spouse of a Medicaid resident in long-term care from being impoverished. So the personal needs allowance is the amount of money the resident can keep for their own use. If the resident has a spouse living in the community, that spouse can keep other assets and income. So the community spouse resource allowance allows the spouse to keep up to about $129,000 in assets that belong to belong to the married couple, but those assets must be transferred into the spouse's name only. The community spouse is also allowed to keep the homestead, so a house that the community spouse lives in that the couple owns, and that also must be transferred into the name of the community spouse within a certain amount of time after the resident goes on Medicaid. And then there's the community spouse maintenance needs allowance. This allows the community spouse to keep the first $3,853.50 per month of the couple's combined income. So, and that number has gone up by over $1,100 in the last 2 years. So the community spouse maintenance needs allowance has gone up a lot. It's substantial at this time. You know, it can still be a problem for some community spouses, but it's a lot of money that the community spouse is allowed to keep before any of the resident's income needs to be paid over to the facility. So if a resident gets $2,000 a month from Social Security, and his wife in the community gets $1,400 from Social Security, they don't need to pay any of the resident's income over to the facility because the wife is allowed to keep the $3,853.50. So their combined income is $3,400. They don't have to turn any income over to the facility each month. If the resident gets $2,000 a month, his wife gets $2,000 a month, they have to turn over about $150 a month to the facility.
I think that's really important information for everybody to know. This is.
Lee, I lost you. You're muted.
Yeah, it keeps bouncing. Sorry. I think it's really important information for everybody to hear, because I think that becomes that scary point. When you have your wife, you live in the nursing home, your wife lives at home, you don't want to take up all the money. You know, if you're on that verge of just being able to make ends meet, and then you can qualify for, you know, public aid, Medicaid, that can be really, really important to know that they're not going to lose their house. So many times I've heard, I don't want my spouse losing her house because I don't have the funds to be able to support living in the nursing home. She'll have to sell her house. And that's really important, I think, for people to hear. So that's, and I love the fact that this has seen such an increase. That is, again, has kept a lot of people from being poverty stricken as they've lived in the community and their loved one is living in the nursing home. So again, long way to go, but at least it can be very, very helpful for people to live a good life. There's another question that actually
so we've got a couple questions about about other dependents. So a child who is a dependent, the question is, what if a resident has both a spouse and a child who is dependent or disabled? So there are dispensations for children under 18 for keeping some of the income. That I don't remember those numbers off the top of my head. There are also, if there are court orders to pay child support, if the nursing home resident doesn't have custody of the child, but there's a court order for child support, Medicaid will exempt the court-ordered amount of child support. If there is no court order for the child support, Medicaid makes a big stink about that. So it's usually worth it to get a court order, even if the parents agree on how much child support there should be. Medicaid's going to be much nicer about it, much more willing to deal with it if there's a court order. There was a question here. What if the community spouse makes over $4,000 on their own? Then if the community spouse makes over $4,000 on their own, then all of the residents' income would be turned over to the facility. So they don't get to keep more because it's the community spouse making more money. Let's see.
There was one question about what if the resident has a foster child who is dependent that was previously.
Honestly, I don't know about that situation. If the resident is in the facility and they are fostering with their spouse, I don't know exactly how that works, but I believe that foster children, there's a stipend from the government to pay for foster children. If the resident was the only parent for the foster child would have to presumably be placed elsewhere, because someone who is a resident of a skilled nursing facility for any length of time can't parent a child.
Mhm.
We have a spouse with assets that have only been in her name, i.e. stocks, the entire time and never under the name of the resident. Is this considered the resident asset as well, or only the spouse? So when you're applying for Medicaid, Medicaid asks about all of the assets of both spouses. I believe that if the spouse can prove that the husband or that the resident has never had any ownership in those assets, that they would not be counted. Don't hold me to that. I actually haven't looked at that in a hot minute. So yeah. So I don't remember there in terms of whether the facility can get at assets of a spouse. There is a law in Illinois that makes spouses responsible for each other's medical expenses. So if the nursing home were to try to sue, like if you've got a spouse with assets only in her name, and resident goes into the facility and doesn't pay what they owe, and the facility can sue both the resident and the spouse and try and get at the spouse's own assets. So that much I can tell you. The spouse's assets are potentially at risk if the resident doesn't pay. I don't recall if Medicaid will exempt assets of the spouse that have never been that have never belonged to the resident.
Yeah, there's a lot of conversation that you hear about with people. One of them came up last week between a conversation that I was having with somebody who called almost about that hiding of assets and trying to figure out how we can hide our assets so Medicaid will pay for the nursing home stay. That doesn't typically work out very successfully, does it, Suzanne?
No, trying to hide assets. So when a resident applies for Medicaid, Medicaid can look back up to 5 years. So any transactions that have happened in those 5 years, Medicaid can look at. So if $100,000 goes to some account, they can look at the bank statements and they will see, oh, $100,000 went away. And they will ask, where did that go? And if that went to a child, not as a loan, not as something that would be allowable, then that is considered for Medicaid purposes a fraudulent transaction, and that $100,000 would be assessed as a penalty period. Penalty periods are complicated, but basically it means that Medicaid won't pay until the amount of time it would take to pay for the facility, $100,000, gets used up. So if the facility charges $10,000 a month, that penalty period for $100,000 that disappeared would be 10 months. So that's 10 months that Medicaid will not pay for. And that, if it happened within the look back period, that's 10 months that Medicaid would not pay for before they will start paying the facility that the resident is at. So penalty periods are very tricky. It sometimes involves facilities eating money because they don't have a place to send someone who doesn't have a payer source. But it can also mean that residents get kicked out and, residents who need skilled care, they're not supposed to send people home who need skilled care, but sometimes they do, or they dump them at hospitals. So you don't want to be dealing with penalty periods.
Yeah,
So-
that doesn't sound good. There was another question that came up. I don't know if you saw that, Suzanne, or not. If the community spouse can show the assets were brought into the marriage, would that be accepted as outside joint assets as in divorces?
I haven't looked at this closely in a minute, so I'm not going to comment on that.
Mhm.
I'm not going to give legal advice about that at the moment.
Yep. Understandable. This is a very complicated topic. So that's definitely understandable.
But
So
go
on,
ahead, Stephen.
sorry, on the note of trying to shift assets or hide assets, don't like get a bunch of cash out and hide it under the mattress, because I had somebody do that. They had sold a truck and they just hid several $1,000s in their nursing home room. It was in a safe. They left, went to the hospital, came back, and their locked safe was now empty. And he called me up about it, and why didn't you tell somebody you had this money in your room? And he said, well, I was trying to hide it from the government. Excellent. You did a really good job with that, because there's really no way we can recover that. So don't go hiding your assets to try and save them, because if they go missing, there's really nothing anyone can do to help you recover them.
Well, and those kinds of situations have become less necessary. So it used to be that when once a resident was on Medicaid, they could only have up to $2,000 in assets. And when we came out of the public health emergency, DHS and HFS raised that to $17,500 in assets, which makes a huge difference. It means that, the resident who sold the truck, the truck sale money would still have been income in the month that he sold the truck. And you technically would have owed it to the facility, but if he had put it in a separate bank account, it's not clear that Medicaid might have noticed it in a redetermination. They might not have. So.
Hi, this is Leslie Burgard from Misericordia. So we have so we're licensed as ICFDD for most of our areas. So does that apply to our areas too? That it's not 2,000, it's 17,000?
I believe so.
Okay.
It's everyone on long-term care Medicaid in Illinois.
Long-term Medicaid. Okay, I'm going to share that with our team. Thank you.
Glad to share that.
Yeah, because when we did get all that money, we were very nervous that they was going to put all of our folks into spend down. And so
You mean
that
all of that money, you mean the
stimulus
money. Yeah, so the stimulus money, this is kind of old news at this point, but the stimulus money, when it came in, was not considered income. And it was not considered income or assets for purposes of the then $2,000 rule for a year. And then before and also all of the asset rules were suspended during COVID. So so DHS and HFS increased the amount of the asset disregard. So they increased the amount of assets that anyone on long-term care Medicaid can keep to $17,500 as we were coming out of the public health emergency. So nobody went into spend down because of that stimulus money, even if they hadn't touched it.
Good to know. Thank you.
Is a resident in supportive living also allowed to have $17,500? Yes, long-term care Medicaid, you're allowed to have $17,500. Now, something to keep in mind, people who are on SSI, the SSI amount of assets you are allowed to have is $2,000, and that has not changed to my knowledge. So there are people in supportive living who are not allowed to have more than $2,000 in order to keep their SSI, but for purposes of Medicaid, $17,500.
So if you are doing a redetermination for Medicaid, and again, some of our guys might have $4,000 or $5,000 because our business office had put that money right into their personal needs account. So we have to show them, so I have just said repeatedly that, most of that money is from that stimulus. It isn't money that is, grown over time, because many of our guys are still just getting $30.
Yeah, so that they're allowed to have, for purposes of Medicaid, they are allowed to have $4,000 or $5,000.
But then they also get SSI as well. So
that's a separate issue with the Social Security Administration.
Okay. Okay.
All great questions. It's like stump the band time for Suzanne. Any other questions? Did you have any other questions out there? Okay. Did you have any more, Suzanne, to share?
That's my last slide. So I'm happy to take more questions.
Okay. Well, I did.
Suzanne, this is Karen. Would you comment briefly on an individual who is over asset on some of the items that they are permitted to spend that won't trigger the 5-year look back?
Could you be more, I'm not sure I'm getting what exactly you're getting at.
It's my understanding that somebody who is over asset can prepay burial.
Yes. So there are things that someone who is over assets for purposes of Medicaid can use those assets for. But again, for purposes of Medicaid, over assets is over $17,500. So you can buy a prepaid burial plan. There are certain limits as to how much you can spend on a prepaid burial plan, if it's irrevocable, if it's revocable, all sorts of stuff. They have changed all those numbers since the pandemic, and I don't have them in my head, but they are available in the Medicaid policy manual, or if a resident has a specific issue, they can contact their ombudsman. We are happy to look it up and figure it out. Residents can also use money that they are over assets to pay other medical bills. They don't just have to use it to pay the facility, like spend down to the facility. So if a resident owes, a few doctors and a hospital $5,000, and they have, $30,000 when they're coming in, instead of spending all that down to the facility and ending up with these bills and collections, ruining their credit, which they may or may not need ever again, they can pay off those medical bills. They cannot pay off credit cards. You can you can only use it for medical bills. And there are a few other things that you're allowed to use those assets for that would be okay with Medicaid.
Any other questions, please feel free, unmute your mic, or you could type it into the chat. Either way you prefer to do it. While people are thinking, Suzanne, I know this topic of Medicaid can be very, create some fear in people. Going on to Medicaid, all of a sudden, I was always had my own finances. I worked, I was able to care for myself. And now all of a sudden I can't do that. I'm entering into a nursing home. I don't want to spend my money because I'm going to run out of money. And then what's going to happen to me? And I don't want to be a person who's on public assistance. Can you speak to what that application process looks like? Is it a really scary thing? Who should be helping me with this? Any of those types of advices, or to help maybe make people be a little bit more comfortable if this is the path that they'll be going down as their future starts to evolve?
So, sure. So first of all, it's important to know that when people go into assisted living or a memory care facility that is licensed as assisted living, those facilities are entirely private pay and Medicaid is not available. So if somebody goes into a facility like that and they start running out of money, they or their loved ones need to start thinking about potentially going to supportive living, which is assisted living but with Medicaid, or to skilled nursing, which is a skilled nursing facility. And so it's important to know whether the facility you're in is a place where you could get on Medicaid if you run out of money. So you can plan for that. There are also skilled nursing facilities that have no Medicaid beds or only have some Medicaid beds. No Medicaid beds, they're all private pay or private pay and Medicare. There aren't too many facilities that take Medicare but no Medicaid, but they exist. There are also the facilities that have some Medicaid beds, but not all of their beds are Medicaid, are called distinct part facilities. So those facilities, you can go in private pay or Medicare, and as your money is running out, you need to talk to them and make sure that the bed that you are in or your loved one is in is a Medicaid bed, or work on getting into a Medicaid bed. So when the money runs out, Medicaid, when you apply for Medicaid, there won't be a problem that, oh, you were not in a Medicaid bed, we can't pay for that time, even though we are a facility that takes Medicaid. So there's a little bit of planning about the facility you go to and the facility you're in. When it comes time to apply for Medicaid, most facilities that take long-term care Medicaid will help you apply for long-term care Medicaid. And those facilities do try to make it easy. It is, it's not an easy process. You do have to come up with a lot of documents. You need bank statements going back a year, and then if they ask for it, going back 5 years. You need, sometimes you need to find marriage certificates for a marriage that happened 50 years ago. They also ask for divorce certificates. Sometimes those are hard, or divorce decrees. Sometimes those are hard to come by if the divorce happened a long time ago, things like that. So but the process isn't scary. It's just a lot of gathering documents, and you turn in the documents, and sometimes they start asking for more documents, and sometimes they will get picky, sometimes they won't. During the pandemic, Medicaid did not have to look at assets, and Medicaid applications sailed through. Now we're back to looking at assets. It's taking a little longer again. But the good things to know are, first of all, when you apply for long-term care Medicaid, you can ask them to backdate up to 3 months. So if, you know, if you run out of money and it takes you some time to gather these documents, Medicaid can backdate. So if you miss a payment to the facility, that doesn't mean that you're going to get kicked out the next month. So you can work with the facility on getting the documents in due time rather than like trying to scramble to get everything in a week. So also the I forgot where I was going with this. So the Medicaid applications, while they're pending, facilities are not supposed to be able to issue a notice of involuntary discharge for non-payment. But if they do, you call your handy dandy ombudsman and we will make sure, and you appeal it, and everyone will make sure that the notice of involuntary discharge is stayed until the Medicaid application is approved, or like is, there is a resolution in the Medicaid application. And if there's a problem with the resolution in the Medicaid application and you appeal, the involuntary discharge keeps getting stayed while that Medicaid appeal is pending. So there are a lot of kind of safety nets built into the system. And we are happy to help you navigate the ins and outs of the system. So if you're having trouble, if the facility is telling you you need something and you don't really understand, feel free to reach out to your local ombudsman and we will try to help. We are familiar with these rules. And if we aren't, we know where to look to figure it out.
Thank you for the commercial. And Stephen did put the contact information for the ombudsman at the beginning in the chat. So make sure that you can go there and be able to click on the link, or always know you can just Google Illinois Long-Term Care Ombudsman and it will take you right to the page, the website. And if you go all the way down, you'll see a listing of where you can click on a link to be able to find out who your ombudsman is. Or you can always reach out to me and I can connect you to, and I'll put my email in the chat. Mary, did you have a question?
Hey, Lee.
Yeah.
Hey, Lee, first, before we go to the question, we've got about 5 minutes left for the meeting. So could you give us a plug for our next meeting?
I would if I knew what the topic was.
Okay.
So right now I have not gotten confirmation back on the topic. So there is an entity out there that's an empowering group that I wanted them to come and talk to us about various things that they're working on, and I have not heard back from them yet. So stay tuned. You'll be getting the invite if you're on our invite list. If not, make sure, give me your email in the chat and I will go ahead and make sure that you get those invites. Also, you can always email me. I did just put my email in the chat. Go ahead, Mary. But our next meeting date will be 2 weeks from today, which is, I don't have my calendar handy. So let me look. The 12th of April, April 12th.
I have it as April 9th.
April 9th. Well, Kelly is in this office with me right now, and she's the one who misguided me. So we'll blame it on.
April 9th, everyone. It's the second Tuesday.
Okay. Thank you. The second Tuesday at 3 o'clock. Mary, did you want to go ahead and unmute yourself and ask your question?
Yeah, this is really more of a comment. If the facility you're in is helping you do the paperwork for your Social Security disability or Social Security, just be very careful to pay attention to how that's filled out. They can make I've seen times when they've made themselves the point of contact for Social Security. There are sometimes power of attorneys that are put in there, all kinds of things. So just be very, very careful.
Thank you for those words of caution. Thank you. Then there were a couple of other questions still in the chat as well. Suzanne, did you want to?
I saw, what's the difference between supportive care, assisted living, and skilled nursing?
And if I could just interject, That is another topic area that we're looking at doing in more detail, so you can talk about it briefly, and then that's another topic that people have asked that question before, so it's a topic I think that we need to talk about during these resident family support councils as well. But go ahead and give them the brief synopsis, because it could be an hour-long conversation.
So supportive living is basically supposed to be like assisted living, but with Medicaid. There, up until very recently, supportive living was not supposed to have memory care, but it is expanding into more memory care now. Assisted living is a lower level of care than skilled nursing. Also, there are a lot of assisted living facilities that are mainly or partially or mainly memory care. So we're seeing a lot of memory care for people who don't have a lot of medical needs, but have advanced dementia as assisted living. So, and then skilled nursing is for people who need 24-hour care. And you know, there are so people who are in skilled nursing can have dementia or not, but they have medical needs that need to be met usually.
And Suzanne, earlier you mentioned Medicaid beds, Medicare beds versus private pay beds. And I just wanted to make sure that it's clear to everyone, when we talk about a Medicaid bed, that's not a line on a spreadsheet. There's nothing that says that the nursing home has 50 Medicaid beds and they can just shift a line on a spreadsheet and you're fine. It's literally like room 105 is a Medicaid bed. Room 106, maybe not. So, when we're talking about that, if you're not in a Medicaid bed in your facility, you may actually have to move to a different room if they don't make the application to make that bed a Medicaid bed.
And often people do have to move rooms when within their facilities when they go on Medicaid, because Medicare will pay for one person in a room, but Medicaid will not. Medicaid wants shared rooms unless you have to be in isolation for, infectious disease reasons.
And along the lines of that question, so if somebody I go into the nursing home because I had a fall and then I get discharged from the hospital and I want to go there for therapy. So I would be on Medicare for that period of time while I'm getting my therapy. Through that determination, I need to stay. I figure out I need to stay. I don't want to go back home. I want to stay in the long-term care facility. And I don't have the funds to do this. And they have no Medicaid beds available. What happens to me?
You can go to a different long-term care facility and enter in a Medicaid bed, and hopefully they will help you apply for Medicaid. You can, if the facility that you are at has Medicaid beds, but not one for you, you can apply for Medicaid while you're there and get into another facility while you're Medicaid pending. There are some facilities that don't want people while their Medicaid application is pending. And that can be a problem, but you can apply for Medicaid while you're at some place that doesn't have a Medicaid bed for you and then go to another facility.
If I already had Medicaid, let's say I was at one nursing home, I had Medicaid, I went into the hospital, decided for rehab, I want to go someplace else, and then I want to stay at that building, but they don't have a bed for me. What happens then? I'm just asking this question because we do get this question a lot.
So facilities, if they have properly notified you when you entered that they are a distinct part facility, and they notify you when they notify you that your Medicare days are running out, that they do not have any Medicaid beds, they can try to discharge you. But if you have some money left, if you have money to private pay for a certain amount of time, you can say, okay, I will private pay while I'm figuring things out. And once you're in that, world of you are a resident at this facility, and it's not just you're being discharged from Medicaid, because there are special rules about that. If they want to kick you out for non-payment, they have to issue a 30-day notice. But even before they issue a 30-day notice, they need to give you an invoice, say that you haven't paid, that you give you a letter giving you a chance to pay. So there's a process. So if you get past that, I'm out of Medicare, and you say, okay, I'm going to pay a little bit, then you're in the world where in order to get rid of you, they need to go through all these steps. So I would say try to get into that world, even if it's only by paying private pay for a day.
Thank you for that advice. And then there was another question, which Stephen did answer. It is an assisted living facility, private pay only. And I believe that you both have answered that question, that yes, it is private pay only. And they do not accept public aid, but there is that supportive living option in Illinois that does accept private pay. And Mary, I don't know why you said sorry, because you have nothing to be sorry about.
Well, and hey, Lee, I wanted to point out with supportive living, you can go in to a supportive living as a private pay individual and then transition to Medicaid. So that's a possibility if you are, maybe at that limit where you only have
a few
maybe you
months
have
of
a few
private
months.
pay.
Yeah.
And there was another question that popped up. Is there any tracking of which beds are Medicare beds outside of the facility? And Mary, I'm not quite sure what that question means. I don't know, Suzanne, if you have a better understanding of that question. Mary, if you would like to unmute yourself to get that question answered.
Basically, I'm just confused how I said it. It's, is there anyone outside of the facility tracking which of their beds are Medicare beds?
I believe they send that to CMS. I believe that CMS has that, and and possibly the Illinois Medicaid agencies as well. But we don't have access to that unless they tell us.
And they
Is
wouldn't
it
be able to
public-
overbill. So if they only had 10 Medicare beds, let's say, and they were billing for 12 people, that would be a red flag because they only had beds for 10 people.
Right. Is there any way, is that public information at all that I could get if I wanted to see?
How many Medicare and Medicaid beds is public information. That's on the IDPH website. There's a listing of nursing homes in Illinois. You can look up any skilled nursing facility in Illinois, or shelter care or ICFDD, and it will pop up and it will say how many beds total, how many Medicare beds, how many Medicare dual certified Medicare and Medicaid beds, how many Medicaid only beds, how many skilled beds, shelter beds. So that list is very, very useful. It is not always completely up to date, but it's definitely the place to start on how many Medicaid beds a facility has.
I'm working on getting it up. It's being slow.
Yeah, it's
broken.
It is being
slow. Always slow.
But I actually think I got the link, so I could plop it in for you here. I plopped the link in. So nope, that's not the right link. Sorry, I'll discount that. I'm going to see if I can delete it. That's not the right link. Yeah, it's spinning its wheels. But you know what, Mary, if you're interested in that, if you Googled, let me find out exactly what you could Google for that.
If you Google IDPH listing of nursing homes, Illinois, that takes you there. I have done that many, many times.
Yep.
Yeah, because
well, and actually, what I was looking at was, I try to do, I'm part of a group that does advocacy for nursing home residents. So we just try and, back up what's already being done out there. We have like weekly meetings with residents throughout the state. But what I've run into at least twice is that while someone was in the hospital, their room still has all their stuff in it, but they're being told that they can't come back because there are no Medicaid beds available.
So they shouldn't be first of all, if they've only been in the hospital for 10 days or less and they are on Medicaid, that's illegal. So for any Medicaid resident, when they go to the hospital, there's a 10-day bed hold. For a private pay resident, if they are willing to private pay for the 10 days, they can also have a 10-day bed hold. Now, they don't necessarily get to come back to the same room, but they certainly get to come back to a Medicaid bed within 10 days. If they've been hospitalized for more than 10 days, they have a right to the first available Medicaid bed when one becomes available. And facilities try to do anything they can to, if they don't want the resident back, to say, oh, we don't have any Medicaid beds, or our only Medicaid bed is in the memory care unit. If the resident really wants to go back to that facility, we tell them, if you're willing to go to the memory care unit for a little while, they're not going to want you there long term, and you don't want to be there long term, but that's a way to get back into the facility.
And that's exactly what it was, where they didn't want her back, and at least in one case it was really bad. But she's a quadriplegic, and literally she knows the staff, she knows the people there, her friends are there. It's been her home, and it's been her home for 10 years. So those type of situations, I'm wondering, I was just trying to figure out if there was any way you could look at what beds are there, what are filled, because she knows enough people in there that would go around and look at the rooms for her. And she tracked down.
So I actually think I know who you're talking about, and we could not help her. They kept saying that things were under construction and they did not have Medicaid beds. She was hospitalized more than 10 days, and we couldn't prove otherwise.
That's a tough situation, and unfortunately things like that happen, but at least she did understand that she could reach out to the ombudsman to try to provide that assistance. But sometimes you get stuck between a rock and a hard place, and there's not much more that can be done, unfortunately.
Well, and another thing that's important to understand is that when you are looking at how many beds are available, you can't just roll down the hallway and see what rooms are empty. A lot of facilities, at least in my area, they've got entire wings that are empty, but they don't have any beds, quote unquote, because they don't have enough staff for those beds. And so that's another important consideration. Now, to Suzanne's point, where they have to hold that bed for the person, they do have to hold the bed, but they might not be able to bring in new people because they don't have enough staff.
All great information today, Suzanne. We appreciate you so much being here today with this. I'm just going to go ahead and I'm going to stop the recording right now. Sometimes people do like to still ask questions after the recording has happened. So thank you, Suzanne. I want to thank you publicly. We really do appreciate your time today. It was a wonderful, wonderful informational topic and session. So we really do appreciate that. So thanks.